Good. Good evening to all of the attendees of the recent conference and of IRRMA members. We're so excited to have Dr. Noar here. Carolyn and Maria gave a very intriguing presentation at our conference and really wanted us to dive a little bit deeper into this new science. So really want to welcome Dr. Noar to present his updates, the scientific background of these discoveries that he's made on the new non-invasive testing for the diagnosis of endometriosis. Dr. Noar is an inventor and physician who practiced for over 30 years in gastroenterology before focusing solely on endometriosis diagnosis. Would love to kind of hear how you did that little hop. Maybe that'll come out in this presentation. He is the director of the Endometriosis and Neuroenterology Research Institute and has numerous publications. So again, welcome. We're really looking forward to seeing what you have to offer.
Thanks very much, and I really appreciate the invite to be able to present this new technology. So what we're going to talk about is something that's quite disruptive, and I know that people hear the word disruptive and think negatively, but what we are disrupting is the problem to obtain a diagnosis. In other words, we're disrupting the inability to have a diagnosis of endometriosis at the right exact point where we want it disrupted. We're going to talk about this brand new biomarker. When I say brand new, I'm talking a little tongue in cheek, and we'll talk about that in just a moment. But GIMA stands for gastrointestinal myoelectrical activity, and it predicts endometriosis. And we'll talk a little bit about the entire road to development. And I always tell everyone, all of the new biomedical engineering students and medical students and physicians who I encounter, if we want to see the future, look to the past. And so we're going to start in 1922 and work our way up to present day. So you can see that this is actually old technology that's really paved the way for what we can do today. Now, I'm going to introduce the fact that this is too good to be true because this is what everybody calls it. It's appropriate to call anything that's near at 100% accuracy that. And as I always say, try it once, and then you will be certain that it works that well. And so we'll cover the foundational concepts and also the results. I just want to point out my disclosure is that I am the inventor and one of the founders of Endosure Incorporated that sells this test. Okay. There we go. As I promised, we look to the past and we go all the way back to 1922, so 102 years ago, actually now 103 years ago, when EGG and EVG, that's electrogastrography, electroviscerography, was first discovered at the Mayo Clinic by Dr. Walter Alvarez. And that was the first recording of a transcutaneous contractility of the smooth muscle of an organ in the abdomen. And it took literally until about 1998 for all that to get figured out so that the company called 3CPM could actually bring this out as a single channel device that was FDA approved and still remains FDA approved today for gastrointestinal motility disorders. Now, at the same time, coincidentally, another gastroenterologist was doing all these very interesting studies with transnasal tubes down into the intestinal tract of women for 24 hours at a time. And he then published in 1998 the thing that actually said that this abnormal motility, gastrointestinal myoelectric activity, was unique to women who had endometriosis and no one else. And we'll get more into what that actually means in a moment. That was brought to me in 2004. So here I am. I'm a practicing gastroenterologist. I'd already invented the electrogastrogram. And John came and said, listen, you need to see what I did in 1998. Can you get your device to look at the higher frequencies so maybe we can detect endometriosis using your 3 electrodes on the tummy? And I said, okay. It took us about 2 weeks to get that done. And we then embarked upon a multiple year study from 2004 to 2015, where we examined more than 4,500 women and men looking to see if we could repeat endometriosis, the same findings, as well as looking at all the other possible diseases, because, right, endometriosis is the great masquerading agent. It could be, is it bowel disease? Is it urinary tract disease, GYN disease? So we looked at all of them to see if we could repeat those patterns that were so unique. And when we found out that we couldn't, except for endometriosis, we began a pivotal trial. I'm going to take a moment to talk about trials. So when I talk about a pivotal trial, We are now in the Women's Hospital of Texas. It's a university hospital, and there's an investigational review board, or as some people in some parts of the world call ethics committee. And they look at your protocol. They have to approve your protocol. They have to approve um, the statistical power of your protocol, and then they supervise it while you conduct the study, and then look at the results afterwards and certify that nothing wrong was done in the conduct of that trial. And this trial was the surgeons who did the surgery were blinded to the results of the electroviscerogram, and the technicians who did the electroviscerogram were blinded to the patient's results of any disease. And so we had a formally blinded study that was done. We needed to have 90 patients in that study to power it properly for each of the three groups. It would be 30 per group. And we had 154 in this particular trial. And we released that on 02, let's see, how does it go? 12/02/2022, lots of twos and ones, very binary, at the AAGL. And we released that data. And on that day at the AAGL in December, the average time to get a diagnosis from symptom appearance to diagnosis for endometriosis fell from an average of 8.6 years to literally only 30 minutes, which is exactly how long it takes you to get a diagnosis with greater than 99% accuracy. And then this trial 2 years later was finally published in the Journal of Clinical Medicine. Again, here is that reference to a paper back in 1998. I did not know in 1998 when I brought out the EGG that this even existed. Now imagine this hit the gynecological news media in 1998 and it was promptly ignored. So we had the secret already for diagnosing endometriosis, but no one was paying attention at the time. Now, what's the basis for this? How does the gut tell us you have endometriosis? And this is one of the more remarkable things. Now, remember, 98 was when John Mathias found this on motility catheters, but for 3 years prior to that, they had already sampled the intestinal contents, the pelvic contents of women who had endometriosis, and they found something remarkable, that there were very, very high quantities of two prostaglandins, which are neurotransmitters secreted by the endometriosis tissue. And by the way, that's no matter where it is. If it's in your brain, if it's in your gut, if it's in your pelvis, in your knee joint or sacrum, it's doing the same thing. And these prostaglandins are absorbed, and then they go through the bloodstream and they go to the liver for first pass detoxification. And it goes through the enteric circulation along the way, and it makes the gut go crazy. Now, why? And that's because of the two prostaglandins. So I'll also point out to you that endometriosis is the only disease that secretes both of them simultaneously. And the other kind of fun fact in this, the half time for the existence of these two neurotransmitters from the time they're secreted by the endometriosis tissue until the time they're destroyed by your body is less than 30 seconds. So that means your endometriosis tissue is putting out a lot of this stuff all the time in order to cause these symptoms. And so what happens is PGF alpha causes simultaneous severe spasm of all the smooth muscle wherever it is, whether it's in the ureters or the fallopian tubes, but in particular in the gut. So you have like diffuse spasm, think like the worst dysentery you've ever had in your life. And PGE2, that's the good prostaglandin, right? That's the one that changes the lining of the vagina, the bowel, the stomach every 3 to 5 days. It also causes normal peristalsis. So imagine you have a normal peristaltic wave and it hits a wall of spasm, it reflects back, and then it comes back down again. And that's where you get these unusual frequency patterns that we see. So before we get to actually what you're seeing, a little bit of basic science. The smooth muscle of whatever the organ is, again, uterus, fallopian tubes, bowel, are controlled by pacemakers, and those are known as the interstitial cells of Cajal, named after Ramon y Cajal, a famous Spanish anatomist, who was the only Spanish physician to ever win the Nobel Prize. And that was, again, look to the past, 1907. Imagine. Now, normal gut contraction and homeostasis that's controlled by these pacemaker cells is 1 to 10 cycles per minute or contractions per minute in the stomach. And then the bowel is normally 10 to 15 cycles per minute or contractions per minute in the small intestine. Large intestine is 3 to 6. Now, these same ICCs, pacemakers, also control the GYN system. So for instance, and that's hormonally influenced. So the uterus and the fallopian tubes at rest are 1 to 2 contractions per minute. But then just prior to menstruation, it kicks up to 5 to 8 under hormonal influence. So it makes the pacemakers work faster. Same thing for just before delivery, before you start going into labor. The fallopian tubes, on the other hand, go from 1 to 2 to 8 to 12. And this is kind of important to think about with fertility because, the fallopian tubes have to take the egg and get it to the sperm and the sperm to the egg and then get them to mix together in the tube and then push the gamete or the fetus, the developing fetus, down into the uterus. And so if all this is going on, you actually have fallopian tube dysfunction at the same time as you're trying to actually develop a gamete or a fetus. So I think this is part of the infertility problem. So that's our basic physiology, and we'll remember that now as we go on. Now, this is a curve. This is if you had a tube, a transnasal motility catheter measuring pressure inside your bowel, right? Down your nose, and the normal one is on top, no endometriosis, and you see it's 11 cycles per minute normal peristalsis. So it goes from one measurement at one electrode to the next in an orderly fashion. But if you look at the one below, this is a woman with endometriosis. This is what John was seeing. These are actually right from his paper. And you can see that instead of 11 cycles per minute, it's a very, very fast pattern of 44 cycles per minute. So it's spastic and it's non-peristaltic, like the example that you see above. So this was that initial aha moment back in the paper that was published in 1998. Now, what happens? Well, if endometriosis tissue is there, it secretes these two neurotransmitters. It causes spastic opposing contraction. It uncouples the ICCs, so there's no more pacemaker cells in control. And this occurs in a typical drug dose response curve pattern. And that's an important point because it means the more active the tissue, the more severe the reaction. And then that helps us later when we try to understand, can we predict response to surgery or medication? Now, uncontrolled small bowel activity, right? Remember, I told you normal is 10 to 15 cycles per minute. We're talking about in the 15 to 200 cycle per minute frequency. And in particular, you'll see peaks at 15 to 25, 30 to 40, 40 to 50, and 50 to 60, which are unique only to endometriosis. So no other disease does this, except for adenomyosis, which is pretty much the same thing, just a different location. When we realized we could sense this back in 2004, I had a moment of humor there, and I was a Star Wars fan. And so I said, listen, we're measuring electrical energy given off by the body and diagnosing disease. We're going to call this the tricorder 3L. And that's what we called it. We call it the tricorder, except that that is a trademark of CBS from the Star Trek series. And so the thing I want to point out is that not only do we detect the disease, but we detect when it goes back to normal. So we can track response to whatever therapy it is that the individual undergoes in order to treat her endometriosis. Now, let's go back to that original tracing on top. This is the same women, but so again, when we studied this, the aha moment for us was we created the tricorder. Does it measure the same frequencies? Well, we went a little step further. Is it the same frequency in the same woman? And so this is the woman who had the 44 cycles per minute with the tube down her nose. And this is her EVG below that, showing the exact same frequency band that we sensed through the transabdominal electrodes. So that's how we had proof of concept, and we really knew we were on to something. Now, when I talk about the pattern over here on the left, notice that you're going to see these red lines are on the bottom, two black lines that are sitting here in the middle. And then above that, you've got these flat blue lines. This is after the patient drinks the water to stimulate the pattern. And they're flat from this frequency of 15 all the way to 60. There's really no activity. It's very random. Now contrast that to these two women, and this is two different women. And notice that this woman has three patterns here, these three patterns here. And this woman here has a slightly different pattern with a lot of predominance in the higher frequency. The neat thing about this is that if you're a mother-daughter, you have the same pattern. If you're a mother, daughter, granddaughter, you'll all have the same pattern if you have endometriosis. But if it's your neighbor who's unrelated, she'll have a completely different pattern. And so these are big variations that we see. But nonetheless, the key is in that 15 to 60 cycle per minute range, you see these, I call them twin peak parallel mountain ranges. This is a classic appearance of what endometriosis looks like. And I think it's easy to see the difference between the two sides. But that's not enough. You have to actually measure the area under the curve. Here's another example of those same two patients, but just grown up a little larger again to show you these are two genetically determined patterns based upon how much of each of those two prostaglandins is being secreted and how the bowel reacts. And these are patients actually from that pivotal trial that we published. Now, to show you even further how impressive this is, because sometimes you show someone a diagram like that, and you show two doctors the same two diagrams, and you get 10 answers. So what we do is you use your math and your science. And so that first band of numbers across the top, this is the patient with endometriosis. And so in the 15 to 20 cycle per minute range, when you look at these numbers in the endometriosis patient, which represents the area under those curves, under those mountain peaks, compare that to the normal patient. And they're off by a factor of 40 to 80. And that's a really good thing. So when you see that, you know that you can use your math to do your calculations for sensitivity, specificity, and predictability. So this was a really important moment. And so what did we do? Well, here's the device before I get onto that. There's a respiratory belt that goes above your breasts that just measures respiration because we want to make sure if you're breathing 20 times a minute, the machine doesn't think that that's the bowel contraction. The device itself is very simple. It's slim. It's the size of two cell phones. It fits in the palm of your hands. It's built to military specs, which is to say, throw it out of a 3-story window and then run it over with a Humvee. You can pick it up and use it, and it'll work every single time. I've tested this, by the way. And then you have these 3 electrode pads, and that's it. This is what goes on the abdomen. The shirt can be pulled down immediately to protect any modesty that's especially important in some religious populations. And those are special pads. They're not like the typical EKG pads that we've all seen or had placed on our bodies, which are wet. These are dry pads, so they're more stable. They are less, there's less of a tendency for artifact, and they give you about a 10,000-fold increase in sensitivity of this very low frequency signal. And these are just proprietary. They go with each patient. They're only used once. So you come in after an overnight fast, the electrode leads are placed on your abdomen, everything is hooked up, and the test begins. You drink a glass of water until you feel full. You recline in a comfortable chair, reclining for 30 minutes, no stimulation, think mini spa day. And at the end of 30 minutes, the machine spits out a result that says, you either have endometriosis or you don't. That means an immediate treatment pathway, which is a heck of a lot different than waiting 8.6 years to even find out you have the disease and then try and figure out how to treat it. So I want to go over our study design because, again, this is very important. When you look at studies, no matter where they are, um, you know, how do you know it's a good study? Well, in this particular study, right, we tick off the first box. Yes, it was controlled by an IRB or an ethics committee. It was properly powered, so we're good there. And then how is the study designed? So this is a controlled trial. So we had non-endometriosis normal patients in cohort 1. So those are our controls. The second control group is the endometriosis group that had surgery first. So we knew they all had endometriosis. And then we had them do the EVG test. And then the third group, this is the key. This is the group that's your verification cohort because nobody knows what they have. They're coming in with abdominal pain. They've had multiple imaging studies. No one's found out what's wrong. They were already scheduled for surgery. We did our test and then they went to surgery. And so nobody knows what they have and everyone's blinded to what everybody has. You look at the demographic data here, and you can see here this cohort 1, which has 62 patients. It needs to have 30 minimum. It had 62, has much less pain than the ones that have endometriosis that you see in position 2 and 3. Now, that would be what we would expect. Another good thing about this study is it was a well-balanced study in terms of the ethnicity. So we know that no matter what your ethnicity is, this test is going to work for you. And we've tested it around the world in just about every country at this point. And this test works no matter what the ethnic origin is of the subject. So now the next thing you do, and I'm going to talk first about the control group. So the control group were women who had no pain, no symptoms, and no endo. And then there were some who had pain due to other diseases. So remember, I talked about confounding diseases in the past, and we looked at 4,500 women to make sure no other disease gave this pattern. Yeah, well, we included people who had Crohn's disease, ulcerative colitis, interstitial cystitis, polycystic ovary syndrome, things that were commonly confused with endometriosis. And we kept them in the same group, but we analyzed them separately. And what you can see here is a comparison. And what we compare is every point in time. So baseline, this is before they drink water. They've now had the water 10 to 20 minutes later, 20 to 30 minutes later, and 30 to 40 minutes later, after they've had the water. And the p-values are all insignificant, right? You need to have a p-value less than 0.05 to have significance. Why did we do this? We did this to prove that if you don't have endo, your test is negative, and it doesn't matter if you have concomitant diseases. That's very important. And by the way, a lot of these women were taking hormones also. So we did not exclude hormonal medication. So here were our results before we did the mathematical analysis. This is just by looking at those lines, the mountain peaks. In cohort 1, where we had 62 patients, we all knew they did not have endo. None of them had that pattern. In cohort 2, we had 43 women who we knew every single one of them had endometriosis, and every single one of them was positive for that pattern. And in cohort 3, we predicted before surgery of the 49 women, again, remember you needed 30 per group minimum, that 47 would be positive at the time of surgery and 2 would be negative. And that's exactly what was found at the time of surgery. And then in case you were wondering, does it matter about the severity? No, it doesn't matter about the severity. These were all equally represented as surgical grades 1 through 4. So severity of disease, the body morphology, whether you're obese or skinny, makes no difference whatsoever. That was in the demographic information there. And where in the body the endometriosis is doesn't matter either. So this was the qualitative, right? Looking at the patterns. And then we're going to look at the quantitative, where we actually look at the numbers. So when we look at the numbers, again, every point in time, every frequency pattern that we could look for, remember, you've got to have, for them to be different between the normal patients and cohort number 1, non-endometriosis, compared to the 2 endometriosis cohorts 2 and 3, look at the p-values. We have p-values less than 0.001. This is really super significant in these patients. So we were able to establish that we could, with this test, say who did and did not have endometriosis with a very high predictability level. But that's not enough just to say that the predictability is good. That's a good thing. Now you do the real statistics. And this is, again, speaks to the quality of the study. And so what do? You use the area under the curve, right? The calculations of the area under those curves, those mountain ranges, to do a logistical regression analysis. This is the classic prediction analysis to determine if someone has endometriosis. And you must set it as a minimum to be positive of 0.5. And then we also used a little bit of artificial intelligence. We wrote an artificial intelligence program to look at other variables to say, if we looked at age, if we looked at pain symptom scores, did it matter, right? Could we get more predictability? And from all of this, we estimate sensitivity, specificity, and then the predictive value. And then one other thing I threw in there is that we saw that the women who were 35 and under had slightly better results than the ones who were 36 and older. So I didn't want to mix them together so that we could have this age discrimination where one might unduly influence the other. So we analyzed their data separately. And here are the results. But before, yes, I have to tell you the story. So 3 o'clock in the morning, my statistician, who is a senior member of the National Institutes of Health, one of their senior statisticians, he calls me up at 3 in the morning. Why are you doing this work at 3 in the morning? I asked him. He said, just get out of bed and look at your computer. So he said, look at these numbers. And so he's showing me, these are called the ROC curves. This is the area under those curves, right? And we want all of the data above this line. So this is all positive, true positives, and below here would be false positives. And we want it all grouped up here in the left upper quadrant, right? We want all the data up here. And so for the age 35 and under, we want to be as close to a value of 1.0 predictively, and we didn't get there. We were at 0.9979. That's really exciting. Couldn't sleep the rest of the morning after that. And even for the age 36 and overs, right, we wanted to be up here at 1.0. We were at 0.9847. Still phenomenal, better than anything that exists to be able to make a diagnosis of endometriosis, let alone the fact that this is totally non-invasive. So now we let the AI go through all of the data at all of the frequency bands and looking at age and looking at symptom score. And we found that if we use the frequency bands of 30 to 40 cycles per minute, 40 to 50 cycles per minute, plus a pain score, and these are for the women who are age 35 and under, we had a sensitivity of 95%, specificity of 96%. Again, better than anything that existed at the time, and a C statistic of greater than 99%. The C statistic, in simple terms, means what's the chance that someone will have the disease if the test is positive? So not quite 100%, just under 100%. Nobody likes 100% in science. So we were very, very happy with these results. And I'm going to point out one other thing to you. Those numbers look really good, but look up here. What if we could have just picked the frequency band of 15 to 20? But we didn't do that. We chose to exclude that frequency band from the analysis. And we did that because gallbladder disease, if present, lives in the frequency of 12 to 18 cycles per minute. And we didn't want anyone to go to surgery for gallbladder disease when they really had endometriosis or vice versa. So that's why we picked the other frequencies in our analysis. Now, the 36 and older were slightly different. They're off by about 4%. So we use the same frequency bands plus the symptom score and age. And so they went from 95 down to 91% sensitivity. 96 went down to 95. And they went from 99 plus to 98% accuracy in diagnostics. And that's still better than anything that ever existed or currently exists. Now, the secret sauce behind all of this, and these are some of the numbers that we use, is we put them all together in this calculator and we look for the probability. And so age 35 or less, age 35 or greater, if the p-value is greater than 0.5, that means you have disease. If it's less, you don't. And so this woman was 31. That puts her over here in this group of 35 and under. She had a p-value of 1, meaning she had the disease. So that's like when you look at a light switch, right? There's the on-off, and then there's the dimmer switch. We also give you the dimmer switch. Now, the dimmer switch is an idea of how active is this disease, which is the metabolic activity. How important is this disease vis-a-vis this particular patient's body? And that number, again, it had to be a 0.5 or higher, was 0.69. So this is a moderately active disease. What does that mean? Well, we didn't know what that meant. So what do? You go in and you do real world activity studies, real world experience. And that's what we did next. So we went to one of the most famous places in the US for this, the Cameron Najad Institute and the Center for Special Minimally Invasive and Robotic Surgery. He's actually one of the ones who invented laparoscopic surgery in the gynecological field. Famous, brilliant man. And so we took 9 of his patients, Everybody, I was blinded to this. Everyone was blinded to whether the patient had endometriosis or not. I went into the surgery for every one of these patients. And something that was really interesting that we began to notice is the patients with the highest grade disease had the highest scores. So all the point 0.9 scores that you see here were all stage 4 disease. And the stage 3 were between point 0.7 and point 0.9. And the stage 2s were 0.6, and then we have other data that shows that the 0.1s are at the 0.5 to 0.6 range. And this has held up in multiple studies done in multiple university hospitals around the globe. Then it relates much more closely, not so much to the grade, but to how active that disease is, how aggressive that disease is. Now, when you have numbers like that, um, you go ahead and you publish your data. Now, that was the first patient we already showed you the data, but we had a lot of people who then said, we don't like you're using the pain score because the pain score is subjective, right? I mean, the contention was almost humorous, right? Women are going to lie about their pain score, so you'll operate on them. Nonetheless, we said, fine, we'll go back and we'll reanalyze the data. And instead, we'll use an AI formula that excludes the pain score. So this is the data that's just been most recently published. And this is the interim data, so it hasn't been completely analyzed, but I can tell you the final set is about to be published and it's similar. And so now look what happens. We took out the pain score. We went back to those frequencies plus others. And gosh, we went from 95% sensitivity to 100%. We went from 96% sensitivity to specificity to 100%. And now our C statistic is at 100% diagnostic ability. Again, that makes people very uncomfortable. So we're going to call it 99 plus. But with this test, we can get as close to 100% as you can ever ask for. And again, we don't even need to use the pain scores any longer, even though they were standardized and accepted pain score data that was used. And here's what that ROC area under the curve looked like. And as you can see, nearly perfect at 1.0, 99.9984. So again, very good data, whether you use pain scores or not. And so as I tell physicians, if you're uncomfortable with the pain score, just use the other calculator. Use whichever one you want because they both do the same thing. So the next thing you do it is, well, you got all this great data, right? So maybe we can use it to see if someone gets better or someone gets worse. Because one of the things we don't have out there is we don't have the ability to say, did I get all the endometriosis when I operated on the woman? Well, here's an example. So we went and we studied it. We said, okay, let's take this. We took a patient who was 2 months post-surgery. Now, this is her preoperative score, that activity index. It was 0.9232, and she had a complete surgical excision here locally by a very talented surgeon here in Baltimore. And her scores went back to normal. They're much less than 0.5. And she became totally asymptomatic. And so he said, all right, that's one. Let's try another. So here's another one. We waited 6 months on this patient. And she went from 0.9979 here with very severe disease. He removed it all, 5 hours of surgery. And now she's 0.03578. So these women are asymptomatic. There's a complete loss of the signal. So we can say that they're negative. And the good thing is that if they start having symptoms again, as many women do, let's say a year later, and the surgeon says, well, gosh, I don't know whether this is your endometriosis to come back or is this scar tissue, you just repeat the test. And if it's negative and it was negative after surgery, then you say, okay, this is scar tissue. What do we do? Do we do some pelvic physiotherapy of the floor? Do we do some abdominal physiotherapy to break up some adhesions? Or do you go in and do surgery, but it's only for the adhesions, not because you think there's endo? As opposed to if it was positive, then you'd be going back in to destroy the endometriosis tissue. So it really completely changes the post-operative decision-making of the surgeon and for the betterment of the patient. So you now have more options. So the next question was, gosh, it works for surgery. How do we know if the medications are working? Because, some of the medications that women are taking nowadays, it kind of suppresses the disease, maybe. It's more of a band-aid, but others actually kill the disease off, especially things that are using progestins. So let's see. Oh, I'm sorry. So here is the here are two examples. So this is 2 months after Regolix therapy begins, right? So the patient is TB, and you can see that she had very little activity to start with. It stayed very little, but she went down 15% on this particular medication and was about 80% less symptomatic. And here's another young lady, 2 months post Regolix therapy, and her patterns were much more prominent and decreased much more prominently. But really, more importantly, is she went from a 0.72, again, 0.5 and higher is abnormal, down to a 0.2 and became entirely asymptomatic. And this is 2 months post therapy. And this is very important because this is in the adolescent category. And adolescents, nobody wants to operate on them. No one will operate on people who are uh, under age 18. They're afraid to do so. And now we can not only tell them they have endometriosis, but we can get them on medication, know that they'll respond to medication, and then measure that response. And when the response stops, and let's say they become symptomatic again, repeat their test and say, okay, yeah, your numbers have come back up again, time to switch drugs or change the dose, and then follow that. So non-invasively, again, with nothing more than a glass of water and a 30-minute rest, we can tell you, do you have the disease? Did it get better? Is it getting worse again? Or is it staying the same and there's a different problem? And that's where we are in terms of state of the art with this. We now have post-therapeutic monitoring. Now, many people ask, where is this approved? I can tell you that as of today, the only country that you cannot have this test on is the United States of America. We're trying to make America great again. Every other country in the world, you can go and have this test done, including as of next month, all of the EU and Australia. So we'll eventually get that done. It's up to the FDA to work through their processes and get us to the point where probably in I would say the last quarter of the year, we should have an approval. And on top of it, we have multiple other centers. And so this is the important part. You do a study. Everyone says, yeah, but that's just you, and you did it under ideal conditions. And we have to have other centers publish their data. And we have that at Sheba Hospital. Their publication is coming out soon. They did a similar study that validated exactly the statistics that we had. Same thing at University of Sao Paulo. This was about 150 patients. That data will be out later this year. The UK, which was the first country to adopt, has been doing this in multiple clinics. In fact, they were the ones who now in the UK, if you are an adolescent and a positive endometriosis test with Endosure, they will put you on medication confidently knowing that you will respond. The CHU Brugman, which is in Brussels, are testing us against transvaginal ultrasound. And they just actually did a partial release of the data the other day. It was very interesting. They called and they said that in every case except for two, if the Endosure was positive, the transvaginal ultrasound was positive. Except in two patients, they had a discrepancy where the Endosure test was positive and the ultrasound was negative. And I said, well, did that concern you? And they said, no, because we took the patient to surgery and they were positive at the time of surgery. So we know we're better than transvaginal ultrasound. And in fact, that's the purpose of our test. Make the diagnosis first, then figure out what test you need next to localize the disease and optimize therapy. And of course, the Cleveland Clinic has had a blinded validation ongoing study, I think, that'll probably finish by the end of this year. So the test is out there, it's being used, the data has been validated, so you can feel confidence in the data. And that's the other thing, by the way, with a published study, there are two things. You have peer reviews looking at your data. And the other thing is that you must sign a pledge that anyone can request your original data set for analysis to see if they can duplicate your statistics. And if you won't sign that pledge, they won't publish your paper. So it's an added benefit for people who review things. So what do we have at the end of the day? We have an accurate screening test that you can use from menarche to menopause. And in fact, this disease probably begins before your periods do. Women who have daughters who are 3, 5, 7, 9, they have been tested with the Endosure test and found to be positive before they begin their periods, years before their periods begin. So some of this is present, and it's not just retrograde menstruation, which is the common feeling. This is all of these studies, by the way, these are surgically verified. So this wasn't, we said the test was positive and we thought the patient was positive. In every case, our studies were surgically verified. You have post-surgical and medical treatment monitoring for recurrence. And this is going to make a big difference, right? So if you have infertility, and we know that 40 to 50% of women with infertility have endometriosis, you want to know who has it and who doesn't, because that's going to affect your initial treatment options. For pelvic pain, we know that 70% have endometriosis. This becomes very important for the pelvic floor physiotherapists because they know that their physiotherapy doesn't work as well in patients who are positive as opposed to those who are not. And then, of course, the group that's the most important to me, well, yes, the most important to me are the adolescents. And we know that every year there's, in the US alone, 1.1 new adolescents beginning with dysmenorrhea that could have an immediate diagnosis and stop missing school and getting back to a normal life because they'll get treated immediately. And then I'm going to direct your attention to this very last point because this was the sleeper that came as a surprise. We brought this test out, and I was approached by some of the officials at WHO, and they said that they had a program to prevent postpartum hemorrhage complications. And I said, that's nice, but we're testing endometriosis. And they kind of smiled at me and said, yeah, why don't you go back and look at the literature and then we'll have another discussion. I felt a little dumb at that moment because when I went to the literature, there are dozens and dozens and dozens of papers that describe that endometriosis is probably the major cause of most postpartum complications, including fetal death as a result of preeclampsia, which is directly associated with endometriosis that's undiagnosed, maternal death from postpartum hemorrhage, as well as placenta previa, preterm birth, and miscarriage, all associated with endometriosis. And they want this test used. And we're going to advocate with them that any woman who is pregnant for the first time and has never been tested and does not know she has endometriosis to start with should be screened. So that if you know, there are actually medications you can take and there are things that you can do to make sure that you will be in a safe place for the birth of your child, both for you as well as your child, to avoid these complications. And that's, I think, one of the most exciting things. Again, if you want to talk about numbers, every year in the United States, there are 1.5 million new pregnancies in women who have never been pregnant before. And that's a gigantic screening population. That's in the US alone, which, by the way, in the Western world has the absolute worst record for maternal and fetal mortality. This test is complementary to current anatomical staging. We do not eliminate the reason to do another test, right? MRI, transvaginal ultrasound, whatever it is you're going to do, that's a localizing procedure. You do that to find that thing before you do the surgery. We tell you, go find it because it's there. It gives you this graduated activity index. It actually shows that spectrum of disease that then becomes reflective of post-treatment success. And it's going to help with new drug development and testing. We have multiple pharmaceutical companies who are knocking on the door, asking if they can use this test with their new drug development to prove that their drugs work and how well they do. And of course, that predicting perinatal complication risks, I think is inestimable. Worldwide, you're talking about up to 1.5 billion screening tests per year that could be done. Finally, the test is low cost and portable. No matter where you are in the world, you can have this test done. It's resource non-intensive. A secretary can be taught to do the test, and you don't need much more. Not to say that secretaries are not also brilliant. There's no biological or laboratory services necessary, so you don't have to collect, monitor, test, and then dispose of biological materials. Low technical skills are required. And so what we've essentially done is we've now decentralized the diagnosis for this disease. There's no more geographical limitation, right? So for instance, in the US, there are these OBGYN deserts, right? In the rural areas, 20% of the women don't have access to OBGYN services. And then there are other deserts. There are in 17% of the population who are in the urban and suburban areas don't have access because of factors such as language barriers or transportation or insurance. We eliminate that because the test is so easy to do and so inexpensive, and therefore there's no financial discrimination. So, as I'm apt to say, if you're in a mud hut in the middle of the Congo jungle, if you're in a tent in the middle of the Sahara Desert or a chalet in the Mount Kilimanjaro, it doesn't matter. If you have water you can drink, access to this test, and a place to recline for 30 minutes, you can have a diagnosis for this disease. So, is the technology too good to be true? Yes, it is, except that it's just that accurate. Thank you very much for your time.
Sure. That was amazing. Certainly lots of food to mull over and be great to see what happens over the course of the next few years. It's just you've had so many publications come out just like in the last 5 years. Hopefully it won't be one of those things that seems to take forever from concept to actual practice where it's available
That will
throughout the
depend
region.
on the country. So, for instance, Australia has already allocated $514 million to make sure that endometriosis testing will be done in all of its primary care clinics around the globe, in which they will place one of these
Mm,
devices in each of those clinics.
mm,
So there are lots of places like that. Brazil is going to do the same thing. That is their pledge because they want this in primary care hands. And the NHS in the UK, which was about to approve the test through its ethics committee, wants to do the same because the primary cares, and I think this will happen in Canada too. The people who can see the patient first can make the diagnosis and then move them to the specialist as appropriate, or begin primary therapy.
mm. That's so exciting. Mary, I don't want to dominate the questions. I'm sure that I know you got in a little bit late, but
Yes,
uh,
hi. Yeah, I'm trying to raise my hand and I couldn't figure out how to do it. But anyway, I wanted to ask you, Dr. Noor, um, do you know about the literature about prolactin receptors and endometriosis and in the endometrium? And have you thought about looking at cabergoline? There's a group of us that are really interested in that, and especially for young women, there's of course different medications if you're talking about medical treatment of endometriosis, but cabergoline maybe might go more to the root. I don't know. Have you looked at that or thought about looking at it?
I think that that's a phenomenal idea, and it's one of the things that we've been trying to find clinicians who will target that and actually do the studies. Some of the more recent studies that have been super interesting is Dynagest, which is a pure progestin, and that actually causes destruction of the endometrial tissue because it prevents it from being able to replicate, and it shuts down telomerase activity. So actually, through natural apoptosis, the tumor just dies. I talk to surgeons all the time who say that people on that drug, when they operate on them, they get inside and they see nothing but necrotic endometriosis tissue in these women. That's just that drug. There's, of course, many others with different mechanisms of action.
Mhm.
Uh, we haven't tested them all. We're hoping as the device gets out there, more and more physicians will be able to test more and more of these agents. Diet alone, right? It should be tested in some of the dietary therapies. I mean, we
All
know
right.
that affecting the estrobolome, which is the estrogen producing microbiome of the bowel, can have a very strong effect on endometriosis by suppressing some of that estrogen that is going to be produced no matter what you try and do to the using GRNH axis inhibitors. So there's lots of exciting new things I think that are going to come out, and I want all of it tested. I'm just dying to see what this activity index looks like. I call it an activity index because when we were in Israel, when they did the studies in Sheba Hospital, it was very interesting. They read some of the studies that we said were positive. The women were negative histologically, and we had the pathologist go back and not me, but the researchers there. And they actually found out that it was endometriosis tissue that had passed on, that had become apoptotic. And when they
Hmm.
looked at the different levels, we could trace our levels back to mitotic activity of the mitochondria. So it's super interesting what we're
Mhm.
going to find with regard to all of this.
I'd like to ask you, in the United States, even if it hasn't been approved yet, is there a way a clinic or hospital group can get a hold of one of the devices to use it for testing, for studies?
Yes, it can't be sold clinically,
Right.
right? So a typical practitioner couldn't do it and then use that to make clinical decisions on their patients. But you can obtain these devices just like the Cleveland Clinic has, and I have another clinic that's in Virginia that's now raised the request. If you have study protocols that you run, you can buy this
Mhm.
device and use it because you're doing it within a protocol.
Okay. And what does it cost?
Um, the current sales price for the capital equipment, I think, is 38.8.
Mm.
And I do know that, so we originally released this device because we felt it fell within our FDA approval from the original device from 1998.
Mm.
And it was being used in Maryland at Mercy Hospital. And they actually demonstrated quite nicely. We have a CPT level 1 code. And so people were getting paid between 450 and 650 to do the tests. And so many others were actually willing to pay $400 cash if they had no insurance. That seemed
Mhm.
to be a very common denominator. In the UK, they pay £500 without batting an eye. But that
Mhm.
comes with a GYN visit. And what's interesting is if you do the numbers, if you were to do the ROI, if you do 10 procedures a week, you pay off the capital equipment in 10 weeks. And the consumable is very inexpensive. It's, I think, around $45 per patient.
Okay.
Yeah, fascinating with the potentials. Be fun to look at the research that comes out. That's it's brilliant.
It's
Uh,
really very rewarding.
Now I'm curious on the you said that first it was started transnasally and then you went to transcutaneous on the sensors. Is there
Mhm.
is there certain body builds where you might get a better result if you weren't using the skin, if you still went transnasal or something like that?
Well, which no one will ever allow you to do a 24-hour transnasal study, not unless you pay them a ton of money.
But
So
didn't you say that's what they were doing initially? Maybe I misheard
that
you.
was John Matthias's original study. Was
Oh, okay.
he's a big bowel motility specialist in GI.
Okay.
In fact, that's
Okay.
so that's what he was doing. And then he came to me and said, "Look, you can sense this stuff through the skin already. Just take your filters off so we can see these higher frequencies." And
Mm,
that's what we
mhm.
did, and then proved
Okay.
it was exactly the same.
I see. Okay. Huh. Well, again, that was a great talk. I know a lot of our members will be really happy to be viewing this. Probably come up with more questions, but we'll look forward to kind of how it develops and accessibility and um, yeah, great work. Thank you so much for coming on.
You're very welcome. And if anyone has any questions, please do not hesitate to direct them to me. I'm always happy to engage in discussion or just answer questions via email.
Excellent. Mary, did you have any other questions? Otherwise, this is like you've just the perfect lecture to finish, 3 minutes before the the time is over.
Oh, that's
Appreciate
really
that.
good.
Mm,
I'm glad
excellent.
I didn't
Yeah.
go over.
Mm. I'm I loved seeing the graphs. I'm a sleep physician, and so we used to cover people head to toe. We still do, but when they came out with the things, with the ring to diagnose sleep apnea, so many of us were thought, no, you can't really do that. But it's just looking at the physiology from a different angle, and so I
Right.
just love that, that this they picked up a signal from just a different way of the reflection of the physiology.
Now,
That is so great.
what I showed you today is the clinical system. That's what's used in it's an RX, what they call RX system. You have to have a experienced person place the electrodes, which is quite easy. Um,
Mhm.
2 years from 2 years from November, we will introduce the home system where people
Okay.
will actually, you know, my you asked about the journey. as a gastroenterologist, I probably referred half the endometriosis back to the gynecologists because I saw all the young women. And of course, you do a colon and an EGD and a CT scan, and you go, okay, right, this is menstrual pain. Guess what the diagnosis is? Go back and see your gynecologist. You do not have Crohn's. You do not have ulcerative colitis. You do not have some very rare form of GI disease. And so it always impressed me. And the stories were always so compelling. I mean, they would bring tears to your eyes. And so um, when I was 12, just this brief story, I was swimming as part of our physical education in school. And, of course, on the days that girls were menstruating, they were by the side of the pool and not swimming. And so one day I noticed a friend of mine, she was 12, didn't get up when everyone else left. And I walked over to her as I was leaving, and she turned to me and she was just distraught, weeping. She fell into my arms. And I said, "My God, Wendy, what's wrong?" And she said, every month it's around the time of my period and they don't know what's wrong with me. Now, right, this is when? This is like back in the 19 gosh, this was back in the 1970s, early 70s, late 60s. Yeah, they don't know what's wrong with me. They say there's nothing they can do, and I'm just gonna have to live with it until I get older. And I wanted to be a physician, and I said, Wendy, I promise you I'm going to do something to try and figure this out. And all of a sudden, here I am with the test that actually helped to figure it out. And I went September to tell her, and she had already actually just died in the summer. So it's kind of a sad story, but there's your inspiration for how you go from a gastroenterologist to someone who specializes in endo.
Yeah. Great story. Yeah. Thanks for sharing that. You will help many Wendy's throughout the world, it sounds like.
Let's hope.
Oh,
Let's hope.
all right. Well, again, thank you. We'll end it here. But I can see that we may be talking in the future to see just how things progress. And
Oh,
Maria and Carolyn, thank you so much for bringing this all to our attention. All right.
okay. Thank
Well,
you.
again, thank you. Bye-bye.
Okay. Bye-bye. Find the off button.